Hello everyone, my name is Ankit Mukhopadhyay. I'm a second year student at RGKMCH College and Hospital, and today we are here talking about a case, relatively rare case, which has been named or which is the title of the video, that is tea colored urine. So, let's talk about the case right now. A 24-year-old Caucasian woman presented to a primary care physician for evaluation of new tea colored urine noticed intermittently over the past 5 days. Her last menstrual cycle was 2 weeks ago, and they have been occurring regularly. There is no history of renal stones, NSAID abuse, weight loss, night sweats, fever, melena, or hemoptysis. Her vital signs were unremarkable. On initial evaluation, the complete blood count (CBC), urine analysis, and renal ultrasound were normal, and urine pregnancy test was negative. So clearly from here we can see that renal stones, there is no history of renal stones. So there is no injury to the kidney. A new tea colored urine suggests that the blood or hematuria is occurring. So we are able to rule out the case of renal stones. NSAID abuse, because we know that non-steroidal anti-inflammatory drugs like aspirin, indomethacin, ibuprofen, etc. Is a COX inhibitor, and therefore it will inhibit the synthesis of the prostaglandin I2 that is responsible for vasodilation in the renal blood vessels. So in case of any NSAID abuse, the vasodilation will not occur. Instead, the vasoconstriction will occur. Renal stones, NSAID abuse, as I was talking, NSAID abuse. So instead of the vasodilation, the vasoconstriction will occur. The kidney will receive less blood supply, resulting in hypoxia, acute tubular injury, and thereby resulting in hematuria, that is, blood in the urine. There is no weight loss, night sweats, fever, or melena, or hemoptysis. So there is no bleeding of any sort occurring from the body of the woman. Her vital signs were unremarkable. On initial evaluation, now we are coming to the evaluation part. The CBC, urine analysis, and renal ultrasound were normal, and urine pregnancy test was negative. But this was done when she was presented to the primary care physician. But after a few days, it was seen that she developed jaundice with abdominal pain. So, this is a very important finding. Let me highlight it. Um, Jaundice with abdominal pain. Repeat testing at the time showed the following: WBC count of 3600 per millimeter cube, which is obviously less. Hemoglobin has fallen down to 4 milligram per dl. Platelet count 189,000 per millimeter cube, which also shows a decrease from the normal levels. The MCV 75, RDW is 28, reticulocyte count is 10.9, normal value is 0.5 to 2.3. So it suggests that the reticulocytes are increasing in the peripheral blood smear. So whenever a reticulocyte increases in the peripheral blood smear, we will suspect that it is a case of hemolysis. So there must be a case of hemolysis. More probably, or more accurately, we can say that it is a case of intravascular hemolysis, because in that condition there is a increased load on the bone marrow. So at an increased pressure, the bone marrow will have to release the premature erythrocytes into the blood, and the precursor RBC cells, mainly the reticulocyte, will be seen at a higher percentage in the peripheral blood smear. Therefore, the reticulocyte count has been increased from the normal of 0.5 to 2.3% to 10.9%. Serum bilirubin is also high. It is high, 7.5 milligram per dl, where it should have been 0.10 to 1.2 milligram per dl. Indirect bilirubin is also high. So both the bilirubin, serum direct bilirubin and indirect bilirubin, so total serum bilirubin and indirect bilirubin both are high, suggesting that, strongly suggesting that there is some sort of hemolysis occurring in the body of the woman. So now let's see the next part. The AST level 213 U per L, and serum LDH is 1500 U by L. So the serum AST, that is aspartate aminotransferase, is normal, that is 213, and but the serum LDH is high, that is 1500 international units per liter, and a high serum LDH, as we know, is a case of hemolysis, or it is a non-specific finding in case of hemolysis, but it suggests that there is certain kind of hemolysis occurring inside the body, which has already been shown previously by the increased reticulocyte count, increase in the total serum bilirubin, and indirect bilirubin. Further, the tea-colored urine suggests that it is a case of hematuria occurring from hemolysis, obvious case of hemolysis. Serum haptoglobin is about 10 milligram per dl, and the urine analysis showed hemoglobin urea. So this is a very important finding in the case hemoglobin urea, because the hemoglobin urea imparts the tea colored urine or the new tea colored urine, which is the case today. So this new tea colored urine is arising from hemoglobin urea, that is the hemoglobin is present in the blood. And from retrospective point of view, if we see the hemoglobin is coming into the blood, obviously because the RBC has lysed, therefore there is a strong indication of hemolysis taking place in the body. Direct Cum test is negative. The direct Cum test is done for to detect any case of autoimmune hemolytic anemia. So the hemolytic anemia that can occur. So from this point of view, so from this point, let me choose another. From this point, we have already demarcated as a case of hematuria, because we are finding hemoglobin, serum bilirubin, direct and indirect and total are raised. The reticulocyte count has already been increased and serum LDH is also high. Therefore, and hemoglobin in the blood, already indicates that it is a case of hemolysis. Direct Cum test is negative. So this is done to rule out the autoimmune hemolytic anemia. Liver ultrasound shows mild hepatomegaly, which may be due to which may be a case of, or which may be due to extramedullary hematopoiesis, to compensate for the decrease in the RBC levels, and no signs of stones or biliary ductal dilation. There is no stones or no obstructive pathology in the liver, which can result in hepatomegaly for that case, or no hepatic mass. So the hepatomegaly can be due to the extramedullary hematopoiesis, which is further strengthened by the fact that there is no obstructive pathology present in the liver. And the flow cytometry of peripheral blood showed the absent expression of CD55, CD59 on 78% of the blood cells. So this is the mainstay for the diagnosis of a case of paroxysmal nocturnal hemoglobin urea. Paroxysmal nocturnal hemoglobin urea, because the CD55 and CD59 are absent on flow cytometry in 78% of the red blood cells. So what is this paroxysmal nocturnal hemoglobinuria, and why is the urine tea colored? So let us see more in, or dive more in details about this condition. So we have already diagnosed it as a case of paroxysmal nocturnal hemoglobinuria. Pathogenesis. So what is the pathogenesis of the disease? For the pathogenesis, to learn about the pathology, we have to first know about the physiology of the body. So in the sleep, that is at the nocturnal conditions or at the night time, body is at a condition of physiological respiratory acidotic state, which means that the blood acid level is high. There is a hypothesis not quite acceptable, that is during sleep the respiratory rate is quite low, or the respiratory center is suppressed, therefore the respiratory rate is lower, therefore the blood carbon dioxide level will increase in the body, and thereby it will result in a acidotic condition. But this is not due to any pathology, this is a physiological condition in the sleep. So this is a physiologically respiratory acidosis. So we can say safely that in any physiological condition, when a patient or when an individual is sleeping, his body is under a respiratory acidosis. So let's see what is this acid doing. Now this acid that is produced in the blood will activate the complement system. Acid in the blood is, has been seen to activate the complement proteins. It will activate the complement system. And as we know from our basic knowledge of microbiology and biochemistry, that the complement activation ultimately results or terminates by the formation of the membrane attack complex, or C5b to C5b to 9 C5b to 9, which will release two enzymes, namely perforin and granzymes. So this MSC that is present here, let me highlight it for you. So ultimately the membrane attack complex is formed. Ultimately, the membrane attack complex is formed as a result of the complement activation mediated by the acid in the blood, or the C5b9. Now the MSC is formed on the surface of the blood cells. So what are the blood cells we know? WBC, RBC, platelets. Very good. The MSC is formed on the surface of the MSC has been formed. Say, let us say this is a blood cell, maybe WBC, maybe RBC, or maybe platelets. And now membrane attack complex like this shown by double lines is formed. So this membrane attack complex, what it will do, we know that this membrane attack complex will destroy these cells by releasing what? Perforin and granzymes. So what is this perforin and granzyme? The perforin will produce pores on the cell membrane of these cells, and the granzymes will result in the killing of the of these blood cells. The granzymes will result in the killing of the blood cells, which will ultimately lead to the osmotic lysis and of these blood cells. So from at this point, we should understand that the blood cells have been destroyed. The RBC has been destroyed, WBC has been destroyed, platelet has been destroyed. So what? So this is occurring during the night time or in the sleep. So when the person wakes up the next morning, what he must have, or what must have been expected from the person, that during his first urine, when he will pass the first urine at the early morning, his urine will present with the same case, that is a tea colored urine will be there, or there will be blood in the urine, because over the night, or throughout the night, we can say throughout the night, the hemolysis is taking place inside the body of the patient. But this is not the case. This is a physiologic condition. This is entirely a physiologic condition. So in ourselves, when we wake up at morning, or when we pass the urine for the first time in the morning, is it loaded with blood cells or not? No, obviously no. It is plain straw colored urine. It is never red colored or any tea colored urine. So what is the factor that is preventing the body from the hemolysis taking place? So what is that factor? So this is a physiological condition. So but the next morning there will be no, there will be still no hematuria. The hematuria will not occur. All these things which we have been reading up till now, the acid activating the complements resulting in the terminating by the formation of the MSC, destroying the red blood cells, WBC platelet, the hemolysis must have been reflected on the urine early morning by the reddish colored urine. So the reddish colored urine is never formed. So what is the factor that is preventing it from forming the reddish colored urine? So even though an intravascular hemolysis is occurring throughout the night, there is no hematuria in the morning. So why is it so? What is the factor that is preventing it? So let's see about the factor. This is because to protect us from the intravascular hemolysis, which might have resulted in the hematuria early morning, two factors are present as surface antigen on the on the surface of the RBC. So two factors are present on the surface of the RBC, which will not allow the complement activation and the destruction of the blood cells, which might have resulted in an early morning hematuria. So, what are the two factors? The two factors, as has been discovered, are CD55 and CD59. CD55 is also known as the decay accelerating factor, and CD59 is known as the membrane inhibitor of reactive lysis. So, CD55, what is the function of the CD55? CD55, it will prevent this, or it will inhibit the C3 convertase enzyme. Therefore, it will inhibit the complement activation and thereby prevent the destruction of the blood cells. And CD59, it will destroy the membrane attack complex, the major culprit which was responsible for the destruction of the blood cells. The CD59 antigen present on the RBC will deactivate, or it will not allow the formation of the membrane attack complex on the surface of the RBC itself. Physiologically, CD55 and CD59 remain anchored on the surface of the RBC via GPI-linked protein. So, what is this thing? Say this is an say this is an RBC. These are the two antigens. Say, for example, this is the CD55. This is the CD59. So these two antigens, which were responsible for inhibiting the activation of the complement system, will remain linked on the surface of the RBC with the help of proteins known as the GPI linked proteins. So the GPI linked proteins will anchor the CD55 and CD59 factors on the surface of the RBC. But what is observed in this in our patient, that even though all these physiological mechanisms are at play, the patient is developing a T-colored urine suggesting of a hematuria, hemoglobinuria, and a intravascular hemolysis. So why is it so? And what is the pathology behind it? This is because in the PNH patient there is an acquired mutation in the PIGA gene. So what is this PIGA? PIGA gene. The PIGA gene or the PIGA gene leads to the deficiency or less production of the GPI anchored protein. So the PIGA gene is responsible for the expression of the GPI anchored proteins on the surface of the red blood cells, which was further responsible for anchoring the CD55 and CD59 antigens themselves. So what is occurring in the PNH patients is that the gene that was responsible for the formation of the GPI linked protein, the gene that was responsible for form the gene that was responsible for synthesis of the GPI linked protein, that is the PIGA gene, is itself getting mutated, and this is a loss of function mutation. That is, the PIGA gene gets deleted or gets deactivated. As a result, the GPI linked protein are no longer formed, and since these proteins were involved in the anchorage of CD55 and CD59, these will no longer remain on the surface of the RBC, and they will not inhibit the process of complement activation. Or on the other hand, we can say that the complement activation process will occur, and thereby it will result in the destruction of the blood cells. So the complement via the membrane attack complex will result in the complete destruction of the platelets, and there will be a significant loss in the decrease in the platelet count, resulting in thrombocytopenia. But what is of more interest is that there will be a partial destruction of platelets also, not a complete destruction, but the partial destruction. Now, the partial destruction of the platelets will release certain clotting factors, and it will also attract other platelets due to the release of certain clotting factors. It will attract other platelets, and it will also activate the coagulation cascade. As a result, it will ultimately result in the formation of a thrombus. So there will be a thrombus formation. So in the patients of PNH, there will be a thrombus formation. Often it has been seen that there are multiple infarcts in the brain produced due to the thrombus formation. So this is one of the etiopathological cause, or the pathology behind the cause of multiple infarcts in the brain. That is a thrombus formation due to partial destruction of platelets. But if there is a complete destruction of platelet, there will be thrombocytopenia observed. Now, what are the patient profile, and is it matching with our patient? Early morning hematuria. Yes, the patient was presenting with a hematuria. The patient was presenting with a hematuria suggested by the T-colored urine. The T-colored urine is suggestive of hematuria, which is further confirmed by the urine analysis showing hemoglobinuria. What is the next classical presentation of PNH? Pancytopenia. Obviously, it is a case of pancytopenia because WBC count is less, platelet count is less, and obviously the RBC count was also less. So therefore, it is a case of pancytopenia. Further, it was a case of hemolysis. As it can be seen, or as I've mentioned earlier, due to the fact that the hemoglobin is less, the reticulocyte count is high, 10.9. The serum LDH is also raised. The total serum bilirubin and indirect bilirubin are also raised. So there is a classical sign of, where is it? Hepatomegaly. So indicating a extramedullary hematopoiesis that occurs in case of an intravascular hemolysis. So pancytopenia has been confirmed. Early morning hematuria confirmed. The investigation of choice is the flow cytometry. So flow cytometry has been done. CD55 and CD59 are negative. So the flow cytometry is revealing that the CD55 and CD59 are negative, which is the main diagnostic criteria of PNH. Now the gold standard is the flared test, that is the fluorescein labeled pro aeroleucin test. which is a gold standard test that can also have been performed, that can be performed for the diagnosis of PNH patients, but that is quite costly. So we will remain on to the flow cytometry or maximum cases. In case of patients, maximum the flow cytometry procedure is done because it is cheaper as compared to that of the flared test. And certain old tests were also performed, but these are no longer done in to investigate for the paroxysmal nocturnal hemoglobinuria patients, that is the sucrose lysis test and the ham test, can be asked in the quiz or any other exams. Treatment. Now, what is the treatment? The treatment is a drug. There is a drug for PNA, that is the eculizumab, and as the name suggests, it is a monoclonal antibody that will prevent the conversion of the C5 into C5a. As a result, it will inhibit the complement activation and it will prevent the lysis, complement mediated lysis of the blood cells. But there is a catch over here. The eculizumab, as it inhibits the complement activation as a whole, it will result in the increased cases of meningococcal infections, because the complement is responsible for killing the larger sized pathogens, namely mainly the fungi like cryptococcus, meningococcus will show an increased incidence of infection in the patients who are receiving eculizumab. Therefore, the eculizumab is preferred, but eculizumab is given in the patients of PNH, but it shows an increased incidence of meningococcal and cryptococcal infection. So the only cure or the main treatment or the definitive treatment for PNH patients is the hematopoietic stem cell transplantation as a whole. So this is all about our case of the T-colored urine, which is a rare case, that is the paroxysmal nocturnal hemoglobinuria, which I've discussed today. So if you have liked the video, please do show your love in the comment section, share it, and also like the video. Thank you.